I may give the word to Professor Vladimir Jurisic, Serbia, Multiomic cytokine analysis in hemato-immunology. Please, Vladimir.
Dear Professor Nicolai, thank you very much for the invitation to be here and present my result and data in this important symposium. Dear chairmans, I'd like to talk a little about cytokine as biomarker, and maybe this will be addressed question from Professor Helzer, how to analyze minimal residual disorders using new marker, new cytokine, and about possibility that we resolve problem. Many people know that cytokine is small peptide produced from different type of cells. Cytokine are produced from B, T cell, from tumor cell, but also fibroblast, endothelial cell also produce cytokine. This next problem is because one type of cell produce different cytokine. Today we speak about cytokine network because, for example, one type of cell produce, as we see, 5 or 6 type of cytokine, and all cytokine working together. Primary, one cytokine induce effect from specific receptor, but this is on minority. But cytokine induce pleiotropic effect. So one cytokine induce maybe proliferation, maybe stimulation, and this is new problem, how to classify it. Today, cytokine. Every day we have new cytokine discovered, and classification is possible to do based on biological effects, classify according per cell that produce, classification based on cytokine structure, or the classification based on cytokine receptors. But classically, and mostly use classification as interleukin with many cytokines. Next is interferon family, also growth factors and stimulators. For example, GSF have important role in bone marrow stimulation, and we have also family TNF, and we have also hemokine. Different family today is described depending on structural. Now, we have also that cell immune system are divided according for production cytokine. So we can discuss about type of cell that stimulator. Other subcells produce mostly cytokine associated with allergy, with some immunity associated with helminth infection. Also, we have immunoregulatory cell that is also complex. We have also cytokine that produce immunosuppressive cytokine, like to IL-10 and TGF-beta. So how to cytokine perform side effect after JAK and STAT signal pathway, that is mostly important and mostly described. Cytokine can induce effect on the same cells, surround, and endocrine effect. So today we have all the complexity about cytokine, and when we look cytokine in tumor macroenvironment, this is very important because many cytokine we found in this area of patients, but with different function. So cytokine with stimulatory effect, for example, that increase activity of NK cell, IL-2, IL-15, IL-20Y, but with different potential effects. Some cytokine do strong NK cell activity, expression of NK receptors, but opposite to that way, we have also cytokine with negative effect, for example, IL-10 and TGF-beta, IL-6, that is mostly investigated now in COVID. So when we classified disorders in hematology, we have data that Hodgkin lymphoma mostly have negative effect associated with IL-6, IL-10, and TGF-beta. In multiple myeloma, TGF is not confirmed. In AML, as different effect have positive or negative effect. We also correlate level of TGF-beta in comparison to different activation and inhibitory effect of NK cell, and we had and we report very good correlation between TGF-beta and absolute number of NK cell and between interferon gamma. So this is absolutely opposite effect. With increase interferon gamma, we have negative correlation. So increased TGF is associated with decrease of interferon alpha. So today, when we speak about multi-omics principle of cytokine that maybe help in understanding this very complex effect, we need to discuss about proteomic, metabolomic. What is important in metabolomics? When we speak about immunotherapy, we use different options. Immunotherapy targets some receptor, but metabolomics is based on situation that some receptors may be proteolytically cleavage, and after multi-drug resistance analysis or after immunotherapy monitoring, if you look only receptors, we of course obtain that during time we have decrease of soluble receptors. But what we measured, we really measured necrosis, apoptosis, or only shedding of receptors. This is very trigger question and we don't know. But analysis is very important in comparison to principle of investigation. So if you look for monitor during time, we need to focus for specific method, specific tissue, and look what is important. Next problem is if you look intracellular signal. This signal is transcriptomic, but many data indicated that no strong correlation between gene expression, transcriptomics, receptor expression of cytokine. This is consequence of epigenomic that can maybe modulate some genomic data. So based on that principle, we now introduce pharmacogenomic. This is principle of therapy that modulate, but the fact is really, I expect so much and expect much more better results, but in reality we have not so good data. So possibility of cytokine determination is also complex, dependent on principle, dependent on model, what we working, what we looking, and what we look for analyze. Many years ago, we look only cytokine in the serum, but this is problem because total values of cytokine in serum represent total values produced from tumor, from immune cell, from tumor tissues around, and we don't know which type of cell is really produce this cytokine level. Next is complicated method to apply in everyday clinical practice, but is produce cytokine from cells. For clinical data, in clinical application, we need to first step, separate type of cell that we need to analyze. For example, CD3, CD4, CD8. We try and we have successfully separated cells from multiple myeloma using immunomagnetic beads, and after that we look after 24 hours, for example, amount of produced cytokine. Next problem is analyze, and possibility also, analyze cytokine by flow cytometry, but this data indicated intracellular amount. The first step is marker cells, and after that use permeabilization and look cytokine intracellularly. This is complex, and of course need to 5, 6, 7 antibody from cell surface monitoring, and after that intracellular monitoring on intracellular analysis. Of course, we have also possibility to look cytokine gene analysis. This principle and this slide just that report before in European Cytokine Network. Which method we can use for intracellular flow cytometry, microsphere-based methodology, that is new method, multiplex method, Western blot method, spectrometry, that is good for proteomics, but for cytokine is not so recommended because there's no chance to analyze in picomolar values. Cytokine production we have analyzed by ELISA, ELISpot, that is cheap, and many labs to apply that system. Of course, for gene analysis, we have PCR, real-time PCR, or polymorphism, like to RFLP, that looking for polymorphism for several cytokines, that is very useful for clinical application, for clinical therapy. So we expect the cytokine is good marker in the clinics, but in reality, this is not so good because many other conditions like cachexia, sepsis, DIC, also modulate values, and we have also tried to predict survival, tumor progression, of course, minimal residual disorders by analyzing cytokine, but this is very, very complex. If you like and look for easy assay, this is ELISA system. We need to reader, we need to absorbance measuring, and we calculate data depending on clinical stage. For example, many years ago, we report data that TNF is associated with clinical stage, presence osteolysis, and we also correlate with other markers, like to LDH, that is good marker for tumor necrosis. During time, we can correlate LDH with TNF, that is good correlation, and also if you look for TNF in the serum, we have positive correlation. But if you look functional activity of that cell after separation, we can see that cell of immune system show it only low activity for IL-2 and no changes in TNF-alpha. So this is capacity of cell to produce cytokine. Next, when we look regarding Durian salmon staging system, we have data that first stage and 4 or 3 stage have significant difference in comparison control. So we have a result that in advanced stage of disease, cell of immune system and circulated cell showing alteration of impairment. This is very important to analyze as we speak in the morning session during time. For example, analyze TNF, IL-T, IL-6, and many interferon, many other application, different protocols. For example, after PDL therapy, we have also possibility to look cytokine in the different type of cells, for example, in the dendritic cells, in macrophages, in NK cell, that is depending what you want. And it is very important to look during time. So after bone marrow transplantation, for example, and before, and I not report data because not calculate, we have now with my colleagues from Belgrade, from clinic before and after transplantation result that we look for TGF, IL-6 and GCF before and after transplantation. If we now to looking for statistical model, I also to have idea to collect much more data because COVID stopped results for 2 years. We don't perform anything, and I expect to prolong results and monitor what is situation in a peripheral blood depending on presence CD34 cell or any other effect. So monitor during successful transplantation. Intracellular cytokine that I reported before is mostly possibly to determine using flow cytometry. This is principle, all people know, and this is also results how to TNF intracellular. We're looking mostly interferon because NK cell has characteristic like to cytotoxic cell, and during different therapy, it is very good option to analyze interferon intracellularly in NK cell. When we look NK cell in melanoma and multiple myeloma, we have data that metastatic disorders, lymph node and different cells type produce very low amount of interferon gamma. This is also difference between CD3 positive, this is toxic, cytotoxic cell, or NK cell with labeled with different marker. Mass spectrometry is new method, a new technology, but is absolutely not used for clinical because it's not sensitive and not chance to determine it picomolar amount of cytokine. So this very interesting slide report, when we compare different assays, we have no absolutely correlation. One assay report, for example, one values, other assay different values, but trend is similar. So this is ELISA, multiplex bed assay, and magnetic bead-based multiplex immunoassay, but we need to select specific assays for specific data. This is also possible to analyze cytokine gene, but how to interpret data. We also have chance to look up and down regulation for several cytokine and look in how relative expression. Next possibility, we can look for real-time PCR gene expression before and after immunotherapy, before after cytokine therapy. Some data indicated changes or no changes. So new platform, after obtaining many data, is need to analyze in single cells because we have tumor heterogeneity, and this is very triggering question, which type of cell have which type of cytokine. Today we have many cytokine and many cells that we need to analyze. This is only hypothetical model, or many new technology and platform open bioinformatic tools and bioinformatic system for cytokine analysis. And what we can do today, we can compare percentage of several cytokines, for example, growth factor, in comparison to chemokine expression, chemokine receptors, and many other. And this network is very complex to analyze ratio between genetic level, or nuclear level, cytoplasmatic intracellular signal, receptor, and cytokine produced in serum. We also need to mathematic model. We use in last time and perform many results about string cytokine correlation model in myeloma, for example, and we put some cytokine like to IL-6, chemokine, TNF, and many different signal, and we look in which percentage is association. Strong association exists between VEGF, IL-6, and we publish data about that. Contrary to gene expression, for example, gene for different cytokine, IL-6 and chemokine, in myeloma in comparison to animal model show absolutely different correlation that indicated that in human we need to specific model. So I will be conclude that cytokine as potential marker have many role in cell regulation. Multiomics approach regarding cytokine estimating involve analyzing but various method depending on tissue, depending on cell type, depending also on principle that we need to use for clinical research. This ELISA is classic, but if you have so much money and if you have translation of research possibility, some clinic like to American or maybe German clinic, maybe possibility to apply multiomic system in everyday clinical practice, but for country like Serbia, we have no option, only for investigation. So next possibility to use flow cytometry. This is okay, a regular protocol that we use in clinic, and multiomic principle analysis with many data can, this is my opinion, better answer to many questions, especially during personal medicine, personal therapy, and that will be future. Maybe help in the future for monitoring on minimal disorders, or maybe to help for individual therapy. Thank you very much for your attention.
Thank you for your presentation. And there's an immediate question.
If I know to answer, but I try.
No, just a short comment. Just a short comment.
Okay.
I think you have to add in for the future autoantibodies against cytokines. It has been demonstrated in COVID-19 for interferon gamma and for IL-6 in children. It's a child with infection.
But looking for, this is very tricky question. If you use antibody for IL-6, if you IL-6 so high, we have activation of immune system, we have immune complex, and you patients die because its ratio between complex is high. But suggesting for COVID protocol is that use receptors only in the beginning. If you 24 hours monitor increase cytokine, if you have double time of cytokine below values very low, you have success. If you have high values, this is not success because no chance to neutralize. So this is very complex immunotherapy protocol, a principle that is dependent on case to case of about amount of cytokine that is already produced. This is experience. And next is problem with cytokine receptors. If you apply one type of cytokine, if you have a cleavage of receptor, we have no effect. That this is need to firstly analyze, but this is expensive. IL-6 receptor, and after that, apply therapy.
There's a comment, please.
Okay.
It's an embarrassing question. in COVID infection, old people die.
Yeah.
Have you found good cytokine tests? Why do they die, and why they have such a strong lung support, lung disorder?
I have data about
is there
COVID.
Is there a cytokine-related connection there in that kind of question?
In a COVID, IL-6 in prognostic factor, and we measured IL-6 that is absolutely strongly correlate with lymphopenia, correlate with the dimer, and correlate with death. And there is problem to apply. But I speak about in a conference biomolecular therapy, and some data indicated that vitamin D, that is not expected, but is not specific immune response, stabilize cell membrane. I have data experiment. I performed data about vitamin D on the cell surface, stabilize cell membrane, no IL-6. If you apply IL-6 as drug, we have no effect. That is absolutely contradictory. But there is one paper in literature that I find it. Vitamin D in high dose have better effect than IL-6 cytokine. That is data.
Thank you very much, Vladimir.